You can hear a small, like an extra noise, a blowing or whooshing sound during the heartbeat. The blood is abnormally flowing across the valves. Hear that? With the word. I need to be on school. Yeah. Alright, so the congenital heart defect nursing assessment, you would assess vital signs, the color of the baby's skin, the breath sounds, the heart sounds. You can palpate the point of maximal impulse, which is against the chest wall. It can be felt in the left fifth intercostal space, mid-clavicular line. Auscultate for heart murmur. Assess for fluid status, which would be dehydration or excessive fluid, and assess the baby's weight. And they might have diaphoresis. The pre-op care for babies that have surgery for these congenital heart defects, you would assess their feeding. You would always encourage breastfeeding to have extra calories and it's more healthy for the baby. If the baby's low in the weight, you may increase their calories by, they may have to have a feeding tube. You also look for signs of infection, encourage the baby to have their required vaccines. Manage cyanosis if the baby has it. If there is any infection, you would give antibiotics. And you would encourage the family to avoid daycares to expose the baby to various illnesses until they get well from their surgery. The post-op nursing assessment also assess vital signs, watch for elevated temperature, look for respiratory distress, monitor pain. You would such as uncontrollable crying, facial grimacing, and the baby might be raising their knees up to their chest. That would be signs of pain. Assess for nutrition, increase calories, monitor the weight changes, and watch for the baby's activity. Make sure they're not lethargic and they're alert. Signs of respiratory distress in a baby or an infant would be grunting, flaring their nostrils, sucked in skin above the collarbone or between the ribs, consistent fast breathing or whistling, coughing, or crackle sounds on inhale or exhale. There's 3 obstructive defects I'll talk about, and they are, and how they got right there.
Yeah, we didn't have. We don't have any of that.
Y'all have this. She was editing it.
Okay, so there's 3 obstructive defects: hypoplastic left heart syndrome, pulmonic or aortic stenosis, and coarctation of the aorta. So the obstructive defects are called acyanotic defects. You would notice a decreased cardiac output, low heart rate, poor color of the baby, cool skin, greater than 3-second capillary refill, decreased urinary output. They may develop congestive heart failure or pulmonary edema. You would also see maybe leg cramps. The feet will be cooler than the hands, blood pressure greater in the upper extremities, and decreased in the lower extremities. So the hypoplastic left heart syndrome is the most severe defect. The left side of the heart fails to develop correctly. You would have a small left ventricle and aorta, and this requires surgery or transplant. It's usually diagnosed by ultrasound before birth. Newborns will exhibit difficulty breathing, weak pulses, and poor feeding. Treatment involves a series of surgeries beginning the first few days of life to create a single ventricle that can pump blood to both the lungs and the body. Here's a picture of that. You can see how that left ventricle is really small and the aorta is really small. Aortic stenosis is a narrowing of the aortic valve, which restricts blood flow and increases workload on the heart. Symptoms include shortness of breath upon exertion, swelling in the legs, fatigue. Is often diagnosed by an audible heart murmur. Untreated aortic stenosis can lead to heart failure, stroke, and death. You can see how the valve is stenosed or smaller. Pulmonary stenosis is the pulmonary valve becomes narrowed. Symptoms include chest pain, shortness of breath upon exertion, and swellings in the leg and feet. And on this side, you can see the normal pulmonary valve is open, and the other one on the stenosis is smaller, so it's harder for the blood to get through. The next obstructive I'm going to talk about is the coarctation of the aorta. And this is the aorta is narrowed. You may have high blood pressure in the upper body and lower blood pressure in the lower part of the body. The child may have headaches, nosebleeds, cold feet and hands. Surgery must be done to widen the narrowed section of the aorta. The cyanotic heart defects is the tetralogy of Fallot, the transposition of the great vessels, and truncus arteriosus. The tetralogy of Fallot is a combination of 4 defects: right ventricular outflow tract obstruction, the right ventricular hypertrophy, ventricular septal defect, and an overriding aorta. This was discovered in 1888 by a French physician, Louis Arthur Fallot. It's also named after the Latin word tetra, meaning 4. It occurs every 1 in 2,518 babies born in the U.S. each year. And without surgical repair, 30% of the children will only live to age 10. With surgical repair, the life expectancy is 30 to 40 years. And that's another reason.
Tetralogy of Fallot. Tetralogy is one of the most common congenital heart defects. It has 4 main features: ventricular septal defect, VSD, overriding aorta, pulmonary stenosis, right ventricular hypertrophy. This is a view inside the right ventricle. This is a ventricular septal defect, commonly referred to as a VSD. A VSD is a large bone between the left and right ventricles. This allows abnormal flow of oxygen or blue blood into the left ventricle. The right ventricular outflow is obstructed, which can limit blood flow to the lungs. This is referred to as pulmonary stenosis. The aortic valve is enlarged and overrides the VSD, which makes it easier for oxygen or blood to enter the systemic circulation. The right ventricular wall thickens or hypertrophies due to outflow obstruction. Oxygen poor, low blood, oxygen rich, red blood, mixed purple blood. This is VSD blood shunting. This combination of abnormalities can result in decreased oxygen in the systemic circulation, sometimes resulting in patients appearing cyanotic or a bluish appearance.
And that just shows a picture of a healthy heart and a heart with the tetralogy below. Some symptoms you would see of a baby with this condition is cyanosis shortly after birth that doesn't respond to oxygen as expected. Dyspnea, which is difficulty breathing, chronic hypoxia, fatigue, clubbing of the fingers, exertional dyspnea, delayed development and growth, diaphoresis, increased work of feeding and poor weight gain, squatting, which increases the systemic vascular resistance, and it always requires surgery. So, often babies that have the tetralogy of Fallot will exhibit a tit spell, which is a brief episode triggered by crying, eating, or just being upset that causes the child's skin, nails, and lips to turn blue or gray. This happens due to there not being enough oxygen in the blood of the child due to their heart defect. Most commonly seen in children with tetralogy of Fallot. Toddlers and older children often squat to compromise for the tat spell to help with their shortness of breath. Squatted increases peripheral vascular resistance and decreases the right to left shunt associated with the VSD. The oxygenated blood is trapped in the legs with squatting, which improves oxygen saturation. So there are two mixed defects, also cyanotic. They're transposition of great vessels and the truncus arteriosus. So the transposition of great vessels is when the pulmonary artery and the aorta are reversed, and this is life-threatening at birth. And that shows a healthy heart, and when the two vessels are reversed. In transposition of great vessels, the aorta is in the wrong position, originating in the right ventricle, and sends deoxygenated blood to the body, and the pulmonary artery originates from the left ventricle, sending oxygenated blood back to the lungs. It can be diagnosed prenatally through ultrasound or after birth by exam, echo, and chest x-ray. It's more common in males than females, and children with this disorder can live long, productive lives with early detection and surgical intervention. The truncus arteriosus is a single large vessel empties both ventricles and provides pulmonary, systemic, and coronary circulation. The child may have cyanosis, dyspnea with activity and tolerance, and you may hear a harsh murmur, and this also requires surgery. So the artery and the pulmonary artery fail to separate during fetal development, which results in one large vessel carrying both oxygenated and deoxygenated blood. There is no cure for this defect. Babies generally have open heart surgery before the baby is 2 months old and periodically as it grows. Surgery consists of building the single large vessel and aorta to build a complete aorta. The next thing is not really a heart defect, but it's also a disease in children, is Kawasaki disease. It's acute systemic vasculitis of unknown origin. 75% of cases occur in children younger than 5. Infants younger than 1 are most seriously affected and the greatest risk for heart involvement. It's not spread person to person. It's most seen in late winter and early spring. And most concerning complication is coronary artery aneurysm, which occurs in 20 to 25% of cases if untreated. There's 3 phases of Kawasaki, and the child will have a high fever that's unresponsive to antibiotic and antipyretics. The child is very irritable. The fever can get greater than 102.2. The subacute phase is the resolution of the fever. The child is at greatest risk of development of coronary artery aneurysm at this time. And the convalescent phase, which all clinical signs of Kawasaki disease have resolved, but laboratory values have not returned to normal. This phase is complete when all lab values are normal, which would be 6 to 8 weeks. So some diagnostic criteria for Kawasaki disease is extremity changes, which is edema and erythema of the palms of and the soles. You also have peeling of the hands and feet. You can see bilateral conjunctival inflammation, which both eyes would be red. Erythema of the lips, oropharyngeal reddening, which they call a strawberry tongue. Their tongue would be red. There would be a rash on the trunk and the perineal area. The child would be lethargic, irritable, and occasionally colicky with abdominal pain. This is a picture of the red eyes, the inflammation of the hands and feet, also peeling, the rash on the trunk, and the strawberry tongue. So treatment for Kawasaki disease would be high dose IV gabagoline. It reduces the coronary artery abnormalities when given in the first 10 days of the illness. Also aspirin, 80 to 100 milligrams per kilogram per day to control symptoms of inflammation and fever. Low dose aspirin is given to the patient with coronary abnormalities until the normal platelet count, and aspirin is continued if coronary abnormalities present in the child. The majority of nursing care focuses on symptomatic relief. So I have a couple of questions. The mother of a baby born with a congenital heart defect is upset. No one else in the family has been born with this condition. To determine the cause of the defect, which question is appropriate for the nurse to ask the mother? A, did you consume any alcohol before you knew you were pregnant? B, is there a history of diabetes in your family? C, was the baby's father exposed to any toxins in the work environment? Or D, do you have a history of hypertension? What do you think? A. Most congenital defects occur in the first 8 weeks of pregnancy and are a combination of genetic and environmental factors. Fetal exposure to alcohol is one of the greatest factors for development of these defects. The second one is the nurse is analyzing data collected after assessing a child with a congenital heart defect that decreases pulmonary blood flow. Which nursing diagnosis would be applicable for this client? A, acute pain, B, ineffective breathing pattern, C, decreased cardiac output, or D, excessive fluid volume. C. Nursing diagnosis for clients with congenital heart defects that increase pulmonary blood flow include decreased cardiac output, risk for infection, and caregiver role strain and activity intolerance. Acute pain and ineffective breathing patterns are appropriate nursing diagnosis for a child following cardiac surgery. And excessive fluid volume is a nursing diagnosis seen in the care of a child with a congenital heart defect that increases pulmonary blood flow. Question 3. The nurse is assessing a toddler diagnosed with tetralogy of Fallot. Which clinical manifestation does the nurse anticipate during the physical assessment? Select all that apply. A, palpable thrill in the pulmonic area. B, nail clubbing. C, cough. D, apneic period. And E, the knee chest positions. The A, B, and E. Manifestations of tetralogy of Fallot include a palpable thrill in the pulmonic area, clubbing of the fingers due to reduced oxygenation, and the knee chest position, which the child will perform to decrease the return of systemic venous blood to the heart. Cough and apneic periods are not manifestations of this defect. Is there any question?